Hi, I'm Steve Ratcliffe. Frank's getting ready to do a great module with you. He's going to talk about restoring short anterior teeth. Before he begins, I want to make sure that you've downloaded all of the resources that are available to you. So if you haven't done that, please go to the meeting resource page and make sure that you've got all of the images and radiographs available as you work through this module. The next thing that I would like you to do before Frank begins is have a short discussion. And I'd like you to consider this question. When you think about wear cases, what makes restoring short or worn front teeth either easy or hard? So spend 5 or 10 minutes and throw that question around and then begin with Frank.
Hi, I'm Frank Spear. I want to welcome you to this module. What we're going to be talking about today is actually something that occurs fairly commonly for most clinicians. That is, patients who have either short or worn anterior teeth and desire an aesthetic improvement, similar to the patients you see on the screen. And in fact, throughout this module, we're actually going to go through the treatment of all 4 of those patients. As a start, what I'd like to do is talk about what my objectives are in creating this module for you. And the first one is to help you understand the outcomes that we typically desire in terms of crown length and also gingival levels, which are really responsible for the overall length of the anterior teeth. We also want to talk about what are the common etiologies that produce a shorter than normal crown, what treatment options exist to lengthen the tooth, if you will, and how would you decide between those different treatment options. So, if we think about it, we can just look at a few examples and we'll start to identify what it is we're trying to achieve for most patients in terms of a final aesthetic outcome. Typically, we think of the central gingiva being even with both centrals, the lateral tissue being 1.5 millimeters more coronal, but also even with both laterals, and then the canines being somewhat similar to the central incisors in terms of tissue height. And what we do know is there's a range of, quote, gingival levels, and there's also a range of crown lengths that are normal for an aesthetic smile in a human. This particular patient happens to have central incisors that have a width to length ratio of about 80%, but we know that other patients who have very attractive smiles might have width to length ratios somewhere down around 70%. The bell curve typically being about where this patient is. Again, we see the tissue on both centrals being equal, the laterals a bit more coronal, the cuspid's about even with the centrals, and in this case, the width to length ratio of the centrals is 75%. And then finally, again, kind of going to the other end of the range, again, we see the same thing with the tissue on the centrals, the tissue on the laterals, the tissue on the canines, and in this case, the centrals have a width to length ratio of about 70%. All definitely within the range of what we typically see in an attractive human smile. So this becomes sort of our target. When we're treatment planning somebody with short teeth, we kind of want to keep this in mind because this is what we'd like to get to in the end result. Something within that width to length ratio and those gingival levels. So for your first discussion, what I'd really like you to do is, as a group, talk about what causes short anterior teeth. What are the etiologies that produce a tooth shorter than normal? In the images you see on the screen, we have 2 patients that have short anterior teeth. They happen to have very different etiologies. I'd also like you to discuss, if you were going to lengthen those teeth, what are the options for increasing anterior tooth length? Whenever we think of somebody having a smile with teeth that are too short, obviously we're going to want to lengthen the teeth. So the discussion is what causes it, and the second part of the discussion is what are your options for how to correct it. So pause the presentation. You can keep the images on the screen if you want, and let's have a discussion about those 2 topics. Welcome back. What I'd like to do now is start walking you through some of my answers, at least. I might not have all of them that you came up with, but kind of the more common answers to the questions I wanted you to discuss. For myself, I typically think of 3 common etiologies that produce short anterior teeth. The most common of all probably being tooth wear, as you see in the image on the screen now. In addition, there are patients that have what we'll call altered active eruption. and there are patients that have what we'll call altered passive eruption. In those instances, they can occur in patients who also have tooth wear, but both of those conditions really prevent the apical migration of the gingiva to a normal location. So in fact, even if the teeth are unworn, they're still actively short-looking. When I think about options for treatment, if you've got worn teeth that are short, one option is lengthen them, restore the incisal edge back to its normal position. Another option, if the teeth have worn and erupted, is you could consider intruding the teeth to put the tissue in the correct position and then restoring the incisal edge back, and now you've got a normal tooth length. You could consider doing the same thing. If the teeth have erupted, you could consider crown lengthening them to put the tissue in the correct position and then restoring them. If the teeth are unworn, crown lengthening alone might be adequate. And then finally, in some cases, we actually end up doing some orthognathic surgery. It could be depending on the case, a full maxillary intrusion followed by restoration, or sometimes simply segmental osteotomies to intrude a segment followed by restoration. But those would be kind of the four common treatment modalities I think about that would help produce a longer tooth. So with that as a background, let's talk about what altered active and altered passive eruption are. So when we think about normal eruption, we realize normal eruption occurs, the roots developing, the crowns moving through bone into the mouth, and typically when normal eruption is complete, what we'll call active eruption, when active eruption is complete, the CEJ is 1.5 millimeters to 2 millimeters coronal. Typically when normal active eruption is complete, the cemento-enamel junction is about 1.5 millimeters to 2 millimeters coronal to the crest of bone. So if we looked at it visually in terms of an illustration, and let me give you a description of what I mean by active eruption. Active eruption is really the coronal movement of the tooth towards the occlusal plane, but descriptively, it's the cemento-enamel junction changing relative to the crest of bone. So in other words, the crown is actually erupting out of the bone. So we all know that in a child, when active eruption isn't complete, the CEJ is under the bone. But as growth occurs and facial growth occurs and eruption occurs, that tooth ultimately ends up with the CEJ 1.5 millimeters, 2 millimeters above the crest of bone. Okay? What then happens is really passive eruption, because we know that once active eruption is complete, the tooth can still look quite short. So even though the CEJ is above the crest of bone, we typically end up with a significant amount of tissue still covering the cervical half of the tooth. And what passive eruption really is, if you look at it from a definition point of view, it's really the apical migration of the tissue and the attachment on the tooth. And so over time, that short clinical crown, because the tissue is up on it so far, starts to migrate apically, and now we have normal tooth exposure. So the challenge is that the treatment for altered active eruption is very different than the treatment for altered passive eruption. The treatment for altered active eruption means the CEJ didn't come out of bone, and you will actually have to lay a flap and remove bone. Whereas altered passive eruption is typically just a gingivectomy. So if we go back to our patient whose complaint is she doesn't like her smile, she thinks her teeth are too small and she shows too much gingiva, we realize that in fact she has no tooth wear at all. This is not somebody who's worn their teeth off, and that's why she looks the way she does. If we measure the width and length ratios of her teeth, they're basically square. And so it'd be very rare to have an unworn central incisor with 100% width to length ratio. What we realize is there's a large portion of this tooth that's still under tissue. So now, in terms of how we diagnose altered passive, altered active eruption, typically we take it and start with a probe the sulcus. In her case, the sulcus is relatively deep, 4 millimeters. So you would look at that and go, well, this is just an altered passive eruption case. Let's just take that tissue away and it's going to look great. The problem is when you're probing the sulcus, you also want to try and find the cemento-enamel junction. Normally, you're going to find it right at the base of the sulcus. In her case, even with a little hooked explorer, you can't find the CEJ. When you can't find the CEJ, if you were to just cut this tissue off, If the bone is literally at the base of the sulcus, you're going to get most of this tissue to grow back. And so a helpful tool is a radiograph. We take a radiograph. We can't see where the bone is relative to the CEJ on the facial, but we can interproximally. And what you'll notice is, in fact, that her cemento-enamel junctions interproximally and the bone are at the same position. This is an example of altered active eruption. Once we have that diagnosis, we now know the only way we're going to really expose this tooth correctly is we're going to have to lay a flap and we're going to have to remove bone. Here you can see the flap laid, and in fact, you can't see the cemento-enamel junctions because the bone is covering them. So this is what we mean by altered active eruption. Here, Dave Matthews, a periodontist, has removed 2 millimeters of bone on the facial, essentially normalizing the relationship of CEJ to bone. The flap is then put back about 3 millimeters above bone, and now we go from 100% width to length ratio. By exposing the tooth correctly, we have a nice, attractive 77% width to length ratio and significantly less gingival display in her smile. So the first thing we think about when we see short anterior teeth is we have to know what the diagnosis is of the eruption of the tooth. Is it normal, or is it altered active, or is it altered passive? The next patient we'll go through is significantly different than the one we just saw because, in fact, she has significant tooth wear. And the presence of significant tooth wear is going to have a major impact on how we think about the treatment possibilities. So what I'd like you to do for a moment is, with this image still on the screen, is have your next discussion. And really what I want you to think about is what are the possibilities that can occur as teeth wear? What are the possibilities that could occur regarding vertical dimension changes? What are the possibilities that could occur relative to tooth eruption? And really the key I want you to think about is, if you were going to treatment plan this patient that's on the screen, how would you know what to do? Would you change vertical dimension? Would you change the tooth position? What are the factors you look at that help you make those decisions? So go ahead, let's pause the presentation and have that discussion. Welcome back. I hope you had a good discussion about the possibilities. What I'd like to do is give you kind of a simplistic but pretty accurate way of thinking about what happens with tooth wear. And what I really want to do is address two concepts: segmental wear versus generalized wear. By segmental wear, what I mean is wear on some teeth, but not all of the teeth. A very common one that we see is, in fact, wear on the anterior teeth with very little wear on the posterior teeth. And we know that it's very uncommon to see an anterior open bite in cases of tooth wear. So what typically happens in segmental wear is not the vertical dimension decreasing. Instead, the teeth as they wear erupt. And the challenge is now, if you simply open the bite and restore them back to what you think is a normal length, in truth, you have to do a lot of restorations, and you usually end up with incisal edges that are too far coronal in the patient's face. The correct treatment typically for patients with segmental wear is to reposition the teeth and tissue correctly and then restore the teeth. In contrast, when we have generalized wear, so wear on all of the teeth in the mouth, now we have a different possibility, because now, in fact, it's possible that the vertical dimension is actually decreased. And in these cases, it may be very likely that you actually have to open the bite. Now, how do you know? It's really the whole concept of facially generated treatment planning. It's placing the teeth correctly in the face that tells you where the anterior teeth need to go. And then the relationship, functional relationship that you provide overbite overjet for the anterior teeth that you've correctly positioned determines if the vertical needs to be increased or not. Okay? So now let's go to a patient with worn teeth, and he has normal active eruption, that is, his CEJ is at the base of the sulcus. He has had normal passive eruption. He has about a 1 millimeter sulcus depth on the facial. So these teeth erupted normally for him. He has very little, if basically no posterior wear at all. So he's a patient who has segmental wear. A lot of wear on the anterior teeth, almost nowhere at all on the posterior teeth. And if you really look going from canine to lateral incisor to central and back across, the tissue heights on the centrals and laterals are telling you that in fact there's been some secondary eruption. As those anterior teeth have worn, they have erupted in a coronal direction. And so this is probably not a patient that we're going to be thinking about opening the bite on. It's going to be a patient that we have to figure out how to get the tissue back in the correct position. So when we think about the process of facially generated treatment planning, it's really the process we go through when we set a denture. We start with the central incisors, position them relative to the face, then the laterals, then the canines, etc. Then we correct gingival levels on that denture, which determines overall tooth length. And we use things like a lip at rest picture. Here you can see he doesn't show any tooth at all. We use a full smile picture. We look at the fact that his posterior teeth are in a nice position and they're unworn. And ultimately, we come up with a concept of where we think his incisal edges of his central should be. Once we have that, that tells us what probably should happen with the laterals, and that pretty much then guides us in the rest of the maxillary arch, which in his case, from canines back, it's really in good position. It's primarily the 4 incisors. Once we identify the correct tooth position, now we can start talking about tooth length. We typically can't start talking about tooth length, crown length, if you will, until we have the edges of the teeth positioned correctly for the face. And how do we alter tooth length? Gingival margin levels. Once you've identified the incisal edge and placed it correctly, you're not going to lengthen the tooth necessarily to change tooth length. You're going to alter the position of the tissue. And the way I usually do it is I measure the width and the length of the tooth relative to my new incisal edge position. In this case, his central is 96%. I'd like to end up somewhere between that 70 and 80%. I usually target around 75 to 77%. A simple formula for you is if you measure the width of the central on a model, or if you will, when I draw these drawings on a computer, if I click on the drawing, it tells me the width of the central in pixels, how many pixels there are across that width of the drawing. Multiply that by 1.3, and whatever number you get, that's the length that will give you a 77% width to length ratio. So in this example, here is where the tissue would need to be for those centrals to have a 77% width to length ratio. We now can then draw in the laterals, draw in the canines, and this is his treatment plan aesthetically. And again, this is a problem-based module. I recognize that there's probably a lot of questions about occlusion and how you're going to keep him from breaking and how did he get this way. And that's not part of what we're discussing here because the module would go on for another day. So we're really focusing on crown length and aesthetics in this particular module. But there's your treatment plan. Now, if that's the treatment plan, we really have 2 treatment options. We can intrude those incisors to that position to get the tissue in the correct location, then restore them. Or we could do crown lengthening. Lay a flap, take some bone away, move the tissue up, and then restore them. So you have those 2 treatment options. So what I'd like you to think about now is let's have another discussion for you as a group. And that is, what factors would you look at in trying to decide between crown lengthening versus orthodontic intrusion? We've got a patient, we've got a treatment plan, we want to move the tissue, and we want to restore the teeth back to a certain position. So we're going to end up doing one of those 2 things. So if you can as a group, see if you can identify the criteria you might look at to make the decision whether you're going to do it with crown lengthening or you're going to do it with ortho. So have fun in the discussion, and after you have a few minutes, come back and we'll see what we did for this patient. Welcome back. What I'm going to do is I'm going to walk you through the 4 considerations that I look at. They're not the only considerations you could have had, and you might actually have some that I don't have, but these are typically the 4 major considerations that I look at in trying to decide between intrusion versus crown lengthening. Number one on my list is the length of the roots. This is a radiograph of a patient who needs their teeth intruded or crown lengthened. And what I would usually do is take that radiograph. On the radiograph, identify the existing crustal bone location and put a line on it. And then ask yourself, how many millimeters of crown lengthening do you need? I'll just draw a line on this one to illustrate. Suppose we needed 2.5 to 3 millimeters of crown lengthening. What you'd realize is now you have so little root left in bone that this is just not a patient who crown lengthening is an option for. So in patients with short roots, we are pretty much forced to use orthodontic intrusion. And what I'd like to do following crown lengthening is I'd always like to leave about 8 to 9 millimeters of root in bone if I can. Now, honestly, we've done some and left less than that and have not had issues. But if you're only going to be leaving 5 millimeters or 6 millimeters of root, that's probably not a great crown lengthening case. Next thing I look at, the amount of actual tooth structure that's above gingiva. Why? Because if I'm considering intrusion, I have to know that following the intrusion, I'll be able to restore the tooth. There's got to be enough tooth structure for me to restore. This particular patient, he actually has plenty of tooth structure. So if you intruded his teeth, you're going to have lots of tooth structure to work with. One of the beauties of intrusion is intrusion does allow you to stay on enamel and to not have to go through the interproximal with your restorations. So if you have really nice teeth like these teeth and you do intrusion, as long as there's enough tooth structure to retain a bonded restoration, you can still do some very conservative bonded ceramic restorations on somebody like this. Third thing I look at, the length of the contact. Typically my target for treatment planning is to end up with the papilla about 5 to 6 millimeters from the incisal edge. That's kind of the contact length that I treatment plan towards. What happens as teeth wear is when they erupt, it's not just the gingival margin that erupts, it's the papilla as well. And so we have to consider contact length in our treatment planning because I don't want to just put the tissue in the correct position on the facial and then restore the incisal edges and have this little short contact. It looks very unattractive. So if the contact is quite short, and this one's 2.5 millimeters, it's quite short, it may mean that papilla needs to be moved apically. Now, what that's telling us is if we do it orthodontically, it's quite easy. We don't open up black spaces. We still end up on enamel. If we move the gingival margin and the papilla apically surgically with crown lengthening, we do open up black spaces. We do probably end up on root surface. We're now going to have much more aggressive restorations in order to treat him. So again, one of the other things that we add to the consideration. And then finally, tooth inclination. Are the teeth proclined or retroclined? His central incisors are quite retroclined. Now, that doesn't mean you can't do crown lengthening, but when we have worn teeth that are retroclined, it's typically very difficult to manage the functional aspects of the case, the occlusion, with your restorative dentistry, because what you really want to do is bring those teeth out into a more normal position. So in this patient, number one, his roots are a bit on the short side, but number two, the retroclined nature of his anterior teeth makes this a much better case to do orthodontically. And also, if you have teeth that are proclined, so they're worn and erupted, but they're proclined, again, those cases, it's difficult to predict exactly where the tissue ends up following crown lengthening. So for me, I view crown lengthening typically as a great treatment. Patients that have nice long roots, often, if they don't have enough tooth structure, it's a great option, but I want the teeth relatively well inclined. So in this particular patient, he's being treated with orthodontic intrusion of his upper anterior teeth, proclining the teeth into a normal position, orthodontic intrusion of his lower anterior teeth. And if you're not familiar with typically looking at intrusion cases, the tooth isn't going into the gingiva. It's the alveolus remodeling. So the distance from CEJ to bone stays the same. The amount of tooth above gingiva stays the same. It's the entire tooth and alveolus moving in an apical direction. Here he is at the end of ortho, and the ortho did exactly what it was supposed to do. It brought the upper anterior teeth out and moved them up so the gingiva is in the correct position, and it took the lower incisors and moved them down, making space now for the restorations. In this case, veneers on the upper anteriors and veneers on the lower anteriors. The left lower central, I believe, was a more aggressive preparation. And now you can see we've got our desired outcome. Tissue heights on the centrals even, down to the laterals, up to the cuspids. And the restoration of the incisal edge on the upper gave us the correct contact length. Here you can see the nice result on the lower anterior teeth. So that's a case where, for me, ortho is a much better treatment for him because ortho corrected the occlusal relationships. Crown lengthening can correct tissue position, but it can't correct occlusal relationships typically. So we've gone through an altered active eruption case. We've gone through a case of where intrusion was the correct option. So now let's move on to another case that combines those two things. This is a patient who has altered active eruption of her maxillary anterior teeth, and she also has significant tooth wear. But she also has posterior tooth wear. So she has both anterior tooth wear and posterior tooth wear. To kind of just get through the treatment planning part before I have you do your next discussion, let's go through the facially generated process. We need to know where we're going to put those incisal edges, and that ultimately will then tell us where we want to put the gingiva. So if we look at her lip at rest, she actually doesn't have a bad incisal display. She shows 1.5 millimeters, 2 millimeters. And there really isn't a correct amount of display at rest. It really depends on the patient, how much their lip moves in a smile. I would say what the incorrect display is at rest is when we don't see any teeth. So in her case, I would probably say that what she shows would be acceptable provided her lip moves enough so that when she smiles, she has a pleasing smile. And so if we look, in fact, she shows all the teeth and some gingiva. So I would guess her incisal edge position isn't bad. It doesn't mean that we can't change it a little bit, either longer or shorter, but it's probably not bad right now. However, if you take a look at the posterior teeth, particularly the first premolars, you realize the anteriors are a bit short. Even though there's posterior wear, the anterior teeth have quite a bit more wear than the posterior teeth do. And so I would guess if we were looking at the occlusal plane, we might even consider lengthening the centrals 1 millimeter perhaps, the right central maybe 1.5 millimeters. And what that's really doing is now it allows us to have a nice smile line with the buccal cusps of the posterior teeth. So, the nice thing about drawing treatment plans is you're not committed. So we can draw this, kind of see how this would play out in her face and whether we could accomplish it. And then if we decide that we don't want to lengthen the incisal edges, we can redraw it and see what else we would have to change in the treatment plan. But for now, I'm going to use that as my tooth position part of our treatment plan. And now we need to do the gingival levels, which is where we're going to correct the length of the teeth. So we come in, we measure her existing width to length ratio relative to our new incisal edge position, and it's 100%. The teeth are square. And so we come in, we do our simple math, target our 77% width to length ratio, and it gives us an idea that that's the amount of change we would need to make in terms of gingival margins on the facial. It gives us basically something very similar to what the previous patient had in terms of a desire to move the teeth apically and then restore the incisal edges down. So we're left with the same two treatment options. And in most cases of anterior tooth wear, there has been some eruption, not always, but in most cases of anterior tooth wear, especially if there hasn't been much posterior wear, you end up with some eruption and you're always left with one of these two choices as to your treatment plan. So now, this patient has something the other patients didn't have yet. This patient has lingual wear. Her lower incisors occlude in those wear facets on the centrals. There's almost no enamel on those lateral incisors on the lingual. And so what I'd like you to do now is, given the options of orthodontic intrusion versus crown lengthening, how does the presence of lingual wear affect your treatment choice? what would be the thought process as a restorative dentist? You're looking at this going, how am I going to restore these teeth? I got to get some room. So I'm going to give you some time as a group, talk about how you would create room. Orthodontic intrusion, crown lengthening. Okay? And after a few minutes, when you're done with your discussion, we'll pick back up. Welcome back. I hope you had some discussions that involved around potentially altering vertical dimension, the fact that if you used orthodontic intrusion would in fact get you space because the teeth would be intruded, and when they're intruded, you would have room on the lingual to restore them. So for me, when I think of cases like this, I still go through my 4 considerations first, and then we're going to add in the fact that we see that lingual wear, and we're going to have to figure out what our choices would be. So the first thing I look at in this patient is she's got adequate root length. If you want to crown lengthen these teeth, you definitely can crown lengthen these teeth. And remember what I told you in the beginning, is she actually has altered active eruption. If you probe her, you can't find the CEJs anyplace. So she does have adequate tooth structure. If you wanted to do orthodontic intrusion, when you're done, there's enough tooth to restore. Yep, ortho intrusion would be an option. But the fact that she has altered active eruption, I will tell you, when you intrude teeth orthodontically in patients that have altered active eruption, the tissue and bone don't always behave as predictably as normal. So to me, the altered active eruption in this patient basically means you're going to be doing some surgery. You just have to decide, are you also going to do some ortho as well? Papilla level, contact length, not bad. We'd like 5 to 6 millimeters from incisal edge to papilla. She's at about 4. So if we restore the incisal edge 1.5 millimeters longer, like we talked about, we'll have a pleasing looking contact. And if we did surgery to move the tissue apically, we'd have a correct tooth length as well, most likely. Now, the other thing that's really in her favor is the inclination of the teeth. They're not proclined, they're not retroclined. But we have that problem. We don't have any room on the lingual. And so we're left with, how in the world are we going to manage this patient to get them the crown length we want, but also get the space for the restoration? In altered active eruption cases, I would tell you the one thing I would pretty much always start with is to do the surgery to normalize the periodontium. So in this patient, the first thing that was done, and I'm not going to show you the whole surgical sequence, the first thing that was done was basically to take the tissue with a gingivectomy, basically up to the CEJ level, and you can see how much tooth there is exposed by just going to where the CEJs are. Then a flap's going to be laid and bone's going to be removed 2 millimeters from the CEJ on the facial only, not interproximally. Now, the good news about this case is because we're thinking of lengthening the incisal edge 1 millimeter, 1.5 millimeters, we can leave the papilla where it is. And so this flap doesn't have to take the papilla out at all. This can just be a facial flap bisecting the papilla, take the 2 millimeters of bone away from the CEJ, put it right back basically at CEJ level. Now, how are we going to get the space about the lingual? Because if we don't do ortho, there's no room to restore those anterior teeth on the lingual. And because there's no enamel on them, it does mean the restorations are either going to be full coverage or a taco shell type veneer restoration. So in this particular patient, the way we're going to get the room to restore these anterior teeth is in fact to open her vertical dimension. We're only going to treat the maxillary 6 anterior teeth in terms of indirect ceramics, but how we're going to manage it is we're in fact going to open her bite using composite on the posterior teeth. And it's a technique that we teach. It's a technique that I've used for years. It's very effective. So here you see the first step, a diagnostic wax-up was done. The vertical was opened on the mounted models. We've now prepped the anterior teeth. We've placed a provisional. Now when she bites, she has no posterior occlusion. But the good news is most of her posterior teeth are unrestored teeth, makes it very easy to bond the composites to close the vertical dimension. So what you see is on the left is pre, on the right is post. The only porcelain restorations, the upper anterior 6, everything else was done with composite. The papilla wasn't moved surgically. She had the facial surgery to correct the active eruption, and then the incisal edge is brought down slightly in order to correct the contact length and also to give us the final tooth length. And here you can see pre and 5 years post-treatment, pre and 5 years post-treatment. So again, another way of addressing short teeth. It involved the surgery we saw with that very first example, the woman who had no tooth wear, but it also involved adding a little bit of incisal edge length. And in this patient, we didn't use orthodontic intrusion because we had to do the surgery anyway, and we had some wear on the posterior teeth. So we used the vertical dimension increase to gain the room to restore the linguals. As we now move into this fourth example, we now have an older gentleman who has very, very worn anterior teeth, but minimal wear on his posterior teeth. He has normal active and passive eruption, 1 millimeter sulcus, the CEJ is right at the base of the sulcus. And if you look at his gingival margins from canine to lateral to central across, there's obviously been eruption of the incisors relative to the cuspids. Remember what normal is. Normal is the centrals basically being at the same height as the canines. So in this particular patient, he actually has some commonalities with the previous two. He has anterior wear and some eruption of the anterior teeth, but he has some other things that are going to make his treatment more complicated. So let's just go ahead and we'll do our treatment planning first. So lip at rest, we don't see anything. His tooth's about 2.5 millimeters under his lip. And I can tell you, my goal is to typically have a patient at least show some of the incisal edges of the centrals. So we're going to have to add at least 3 millimeters to his centrals. His lip mobility is actually not bad. So if we add 3 millimeters to his centrals, we'll get to see a little bit of his centrals at rest, and he'll have a pretty decent looking smile once we correct the length of his anterior teeth. Okay? So we come in and we do our drawing, same as we've done on all the other patients. In his case, as in the first patient that we used the intrusion on, the posterior teeth are actually quite good. They're right where you'd like them to be. So if we treat effectively first premolar to first premolar in him, we can correct the tooth position from an aesthetic perspective. Now, the next thing we have to do is we've got to correct the crown length. And it's just the same formula. Measure the width to length ratio, and here's what it would look like for him if we changed him to a 77% width to length ratio relative to our new incisal edge position. Now, I mentioned contact length and papilla height. I just want you to see in this particular patient, he's a good example of what can happen. Is our goal basically for papilla levels is to have that papilla 5 to 6 millimeters from the incisal edge of the centrals and then have it symmetrical. So the papilla between the central and lateral, the lateral, the canines, they're all on the same level. What happens as teeth wear, especially if they wear asymmetrically, in other words, if some teeth have more wear than others, they erupt more. So if you'll notice, his papilla heights are all over the place. The papilla levels between the right lateral and right central are way coronal, and that's because those teeth have actually worn and erupted the most. So in his treatment planning, we're going to have to correct the papilla levels, not just the gingival levels. Now, ultimately, we can do it with our same options. We're either going to do it with orthodontic intrusion, or we're going to do it with flap surgery and bone removal. So that part's not going to change. We're still down to those same options. So let's go through our considerations. You look at the radiographs, and that radiograph in the center of his centrals looks a bit foreshortened, but if you look at the others, he has very nice root length. So if you want to crown lengthen, no problem. What he doesn't have that all the other patients have had is tooth structure. His wear is so advanced, there's nothing there. You look at that arrow, that's there's no palatal tooth structure. So if you were going to treat him and you tried to prep the teeth right now, there's nothing to prep on the palate. So that's going to have to factor in to how you treatment plan. Do you do crown lengthening? Do you do intrusion? It's just like in the previous case, we had to factor in how we get lingual space. In this case, we have to factor in how do we get enough tooth structure to hold a restoration on. Now, papilla levels contact length. Actually, the papilla height between his centrals is quite good. And one of the consequences of intrusion is as you do intrude teeth, if they have a nice contact length to start, as you intrude them, the contact actually gets longer because the papilla moves apically. So sometimes intrusion actually makes the teeth not as pretty as crown lengthening. Sometimes intrusion actually can end up with a contact length that's not as attractive as if you did crown lengthening, but oftentimes that's a compromise you have to make. In his case, the papilla level between the centrals could be left, provided you can figure out how to restore the teeth. And finally, the tooth inclination. They're nice. They're not proclined. They're not retroclined. So this is not a case where you need the ortho to be able to correct the position of the teeth. What you're really left in this case with is he could do intrusion or he could do crown lengthening, but how are you going to restore the front teeth? And so what I'd like you to do is have a discussion about if you did intrusion, you could get the tissue in the correct position. It would correct papilla heights. It would correct gingival margin levels. But how will you then get retention and resistance form, as opposed to if you do crown lengthening? So have a discussion about those two issues in this patient. And when you're done, we'll come back and see how he was treated. Welcome back. I hope you basically came to the conclusion that in this patient, if you do orthodontic intrusion, it's going to be tough. And so really, my opinion on him, since he has adequate root length and the position of the teeth is good, is I would tend to crown lengthen and restore these teeth because it would give me retention and resistance form. Whereas if I did intrusion, I'd pretty much have to do endo, post and cores, and then restore them. So as long as he has enough root length, crown lengthening gives us tooth structure that we don't have. Now, in cases of tooth wear, in order to really have the surgeon manage the tissue heights correctly, it's very helpful oftentimes to either bond the worn teeth with composite, or in his case, I put in a provisional. It's splinted from canine to canine. That's what's holding those incisors on because the preps are just little bitty things. But the beauty of that is now I can correct the incisal edge relative to his face so that the surgeon can use the incisal edge as a reference position. So now a flap is laid. This is what the bone looked like before any bone removal. And now this is what it looks like after facial bone removal. And because the incisal edge is our reference, if I know we want a 10.5 millimeter long central, the surgeon will typically go from the incisal edge of the central and place facial bone 13.5 millimeters away. We usually get 3 millimeters of tissue above bone, 2 millimeters of its biologic width, another millimeter of its sulcus depth, so we get our 10.5 millimeter central. And then typically, we end up measuring from incisal edge to interproximal bone between the centrals, and that dimension is typically 10 to 11 millimeters. That will give us, we usually get a 4.5 to 5 millimeter tall papilla above bone, and we typically want a contact that's 5 to 6 millimeters tall. And so that dimension, that 10 millimeters, 10.5, 11 millimeters, usually gives us the correct papilla height and contact length. And then when everything is sutured, it's sutured 3 millimeters above bone on the facial and somewhere around 4.5 to 5 millimeters above on the interproximal. In this case, we took a little more bone interproximally so that we could get more tooth structure. And then, of course, we had to take about 3 millimeters of palatal bone so that we could expose an additional 2 to 3 millimeters of tooth structure on the palate because there's just no tooth structure on the palate when we started. Now, if we look at the case following healing and then tooth preparation, now you can see the prep length that we achieved from crown lengthening. Of course, that kind of surgery opens up black spaces. It's all on the root surface, so it requires a much more aggressive restoration. So that's why oftentimes if intrusion can be used, we can avoid some of this. But in cases where there's just no tooth structure, you don't really have a choice. You're going to need to do circumferential surgery unless you want to do the endo and the post-course. Here you can see what the soft tissue looks like. This is probably a 1-year recall after seeding. And there's the case before and after. In his case, he actually did his whole mouth. Aesthetically, it came out much better for him that way. But in terms of just treatment planning him, we really could have treated just his upper anteriors and his lower anteriors if we would have crown lengthened the lower anteriors as well. We didn't need to change vertical dimension at all. And again, the before and after. So what I hope I've done in this module for you is given you some ideas about, what our outcome is, what we'd like to see in terms of gingival levels, gingival heights, if you will, on centrals, laterals, and canines, what we'd like to see in terms of width to length ratios, typically of central incisors. And people often ask me, well, what about the width to length ratios of laterals and canines? Once you get the centrals correct, honestly, as long as the laterals are symmetrical, I'm not as concerned about proportion. I'm just concerned about is it pleasing looking. In addition, I hope we've given you some ideas about the etiologies of what produces shorter than normal anterior teeth, primarily tooth wear, altered active or altered passive eruption. Hopefully you've now got an understanding of how to diagnose altered active versus altered passive eruption, what your treatment options are. If it's altered passive and the CEJ is in the right place, honestly, it's typically a gingivectomy. That would be a patient that has a very deep facial sulcus on the order of perhaps 4 or 5 millimeters. And then finally, what I really hope you've seen is how to work through the process when we've had eruption of the anterior teeth and really focus on, do we do orthodontic intrusion? Do we do crown lengthening? And those 4 considerations are really important to me, of root length, amount of tooth structure available to restore, the contact length in the beginning, and then the inclination of the teeth. So it's been my pleasure sharing this with you. We have a lot of supplemental information in our digital suite that covers these topics as well. And so we're going to be getting you that supplemental information so that you know where to go on the digital suite to find it. But I hope you've enjoyed this session as much as I have. Thank you.
I hope you've got new insights on short front teeth. You will be receiving an email within the next 24 hours with a list of resources that are links to additional courses at Spear Online. I know that you'll find them valuable in enhancing your knowledge on the topic of wear, and you'll also find resources there that will help your team become more engaged with your practice. Thanks for being with us.